So, welcome everybody. So just thinking about, induction in the time of plague. Actually, it's this time of year, isn't it, when we start thinking about induction, thinking about new ST1s, saying goodbye to our ST3s, all of that stuff. And it's all been pretty chaotic, hasn't it? And then all of a sudden we go, oh, well, yeah, we've got this timetable. We send them off with the district nurses and they sit in with everybody, and they go out with the health visitors, and they go off with the nurses. And, oh, it's great because sometimes the midwife will have them too. And they go and hang around in the back of pharmacy and learn what community pharmacists do. And then we suddenly go, oh, are we allowed to do that anymore? What are we going to do with them? So if you're anything like me, you suddenly have this bit of a panic, thinking, what on earth are we going to do with our registrars and with our induction programme? So, just thought of some things that we might want to be thinking about. So, essentially, there's going to be quite a lot of participation from you guys tonight, some brainstorming, thinking about some shared experiences, because some of you will have had some experiences with some of the issues, and some of you may have ended up with a new trainee who has started even since COVID has happened. We know that rotations were pretty much completely stopped in April, but there were some people who, for very particular reasons, had to be moved. So you may have some experience of having done some induction. You may have inducted other people. You'll have had new starters in other roles who will have come along, and you might have thought about how you've done it. So you might well have some experience, and you might have started thinking about all of this. And some of you may be efficient enough that you've all actually arranged your induction program already, and that's all sorted out, and you're here thinking, we're ahead of the game. And if you are, brilliant, really hope you're going to share your experiences. So we're going to share some experience, do some small group stuff. And then I hope by the end of this, we're going to have a bit of a capture of actually a bit of a how we're planning to do things, recognizing we're all different, all our practices are different. And that's the joy of general practice, isn't it? Is the fact that practices are really different and we all do things in slightly different ways. But if there are really good ways of doing things, it will be helpful to share, and it might be really useful if we can think about experiences that all of our trainees are managing to get or not managing to get, rather than 2 or 3 weeks in, they go, well, my friend managed to do this, what about that? And we're thinking, oh, that's a really good idea. Why didn't I think of that? So that's sort of where I was aiming to go with it. Does that sound like a reasonable sort of a thing that we're hoping to cover? Some nods from people who got their cameras on. Fabulous. So going to start off with a poll. So can you see that? Oh, I'm going to stop share, don't I, to get the poll to come up. So, oh, it's disappeared. Bear with me. So can you see that poll? Poll there? No, poll's not working. Brilliant. That's not great, is it? Let's kill it off and try again.
I could certainly see it.
So, we'll just share the results. You'll see that. So, looks as though, yeah, delighted to provide the service where, nobody was bothered about it until Tara suddenly put this terrifying idea into their heads that it might be something that's worth worrying about. So few people who think, okay, cool, this is all going to be fine. Few people who are pretty worried about it, and some people who are thinking, oh, I don't know how worried I ought to be about it. Perhaps the PDs know something that I don't. So that's kind of where we're at with it by the looks of things. So I'm going to just send you off into some breakout rooms for about 5 minutes. And what I want you to do is just to have a think about what you are worried about. And yeah, different people might feel differently about things, but just having, I'm going to give you about 5 minutes or so just to come up with the things that you think you are most worried about. So just have a look. I'm just going to make sure we've got a little bit of a mix of people from different practices going off together, so that we don't have everybody who all works together, because if you were going to solve that problem together on your own, you would have done it already, wouldn't you? So there's no point in doing that. Okie doke. So I will come and join some of you in a bit. So things that we thought that we might want to be thinking about here were things about risk assessments. So risk assessments for rooms, risk assessments for activities, risk assessments for the registrars themselves. I'll talk a little bit more about that as we go on, but we've never really done that before, have we? Because you kind of have a room and the CQC said it was all right, or the CQC haven't been for ages, and you go, well, here's the registrar room, in you go. Oh, well, there's somebody sitting in. Okay, yeah, right, okay, well, we're doing a joint surgery this morning. Haven't ever actually considered how many meters are there between you and the other person, and is it okay to be in the room, and is the room even big enough to allow 2 people in at once? Least of all, actually, you know, what is their risk level? Are they even allowed to do any face-to-face work? And particularly focusing on shielded registrar and extreme distance registrars. I know some of you have had some experiences and have done an amazing job with some people who are currently shielding. So hopefully we might be able to share some of the experiences that you guys have had in doing that and thinking about the pitfalls. Actually teaching telephone skills, teaching video skills, and actually recognising that often we teach them around the same time as ordinary communication skills, but actually the way that we're working at the moment is different. So they're sort of add-on skills that we or our ST3s have learned on the background of already having our face-to-face skills and thinking, well, what are we going to adapt and what are we going to lose from this? But actually, if you've got somebody that's only ever worked in hospital before, has no real concept of what a GP consultation looks like, or perhaps has never worked in the NHS before and is going to arrive in the UK in 2 weeks' time, do 2 weeks of isolation from whatever country they have been training in, having been recruited via MS Teams, you know, from 8,000 miles away, arrive in a GP surgery, having never set foot in a GP surgery before. Actually, that's an enormous ask, isn't it? To actually think about, you know, what are we actually training them for and how are we training them to do it? IT. Because again, in hospitals aren't really very IT heavy places. And we've got really good at IT in primary care, and we're using all this stuff, aren't we? You know, kind of go, oh yeah, I've got Accurix, oh, this one's a Teams meeting, this one's a Zoom meeting, this is a this is a whatever. And we just get on with it and use the tech, but actually some of them may never have used any kind of clinical IT stuff before. And of course, previously when they've got stuck, they've probably also been asking for a debriefing, you know, for somebody to come in before the patient leaves the building. So the fact that they can't actually work out how to write it up on system 1 or print a prescription, we kind of go in and help. And of course we can go in and help, but how do you go in and help? How do you teach them? How do you get it so that you can both see the screen and you can play around if you're meant to be 2 meters away from them? Mandatory stuff, so things like safeguarding, information governance, BLS, all of those things, which I suppose, particularly given that some of the ARCP requirements have changed, the fact they now have to do level 3, they need level 3 child and adult, they need BLS annually. Just thinking it's probably worth sticking that in induction at the beginning, making sure that they've done it, because it's important, it's useful, it can be part of your induction program. But has that been in your induction program before? Some practices, I know it very much has been, and in some others it definitely hasn't. Visits, home visits. How do you teach them to do a home visit? Are the patients going to be okay with there being more than one doctor in? I had a patient, and I did a visit a few weeks ago, where the patient and the patient's son were absolutely apoplectic with rage when I got there. I'd never met them before, and absolutely laid into me and then apologised for the fact they'd never met me. They'd rung for a visit, they'd got me, they didn't know who I was, they didn't know whether I could be trusted to come into the house, and were absolutely furious that the care agency had sent an apprentice carer along with a main carer who'd come in that morning, and they were sort of saying, well, what's the good of shielding my dad? What's the good of this if the care agency is going to bring some other person in to learn on the job? And I was like, oh, okay. And they were quite apologetic at the end, but actually just thinking the ethics of bringing another doctor in, because we don't necessarily always, I think maybe we should ring up and say, I'm going to be, or even if we did, we might say, I'm going to be bringing Dr. Bloggs, our new doctor, with me today. Is that okay? No, I'm going to be bringing Dr. Bloggs. Dr. Bloggs will be wearing PPE. Dr. Bloggs has been self-isolating for the last 2 weeks. Dr. Bloggs doesn't go to the pub. You know, what are we going to be doing in terms of discussions? And what does a visit feel like? Teaching them those PPE drills. Actually, you know, that whole getting changed in the street thing, which is a nightmare. How do you do that? How do you teach that? How do you teach that effectively? Can you put them in your car? Probably not. So did you drive in 2 separate cars to the visit to go together? KEPs. So when I went into one of your small groups, you're pointing out, okay, well, you can teach people to do examinations over video link, which is a really great skill that we're all learning now. But does that translate into being able to examine people in real life? Maybe, maybe not. But we probably want to know that they're competent at physical examination before we start letting them do any face-to-face work, don't we? Well, how can we work that out? So do we go in the room? Is that okay? Is that not? Are they competent? How do we work that out? Stuff about shadowing. Do we let them sit in with the nurses? We let them sit in with us? But actually, what about that richness of experience of the primary care team, the multidisciplinary team, district nurses, health visitors, community matrons, people who may previously have welcomed them, taken them, and really enhanced their training experience? Is that going to be possible? What about care homes? Is anybody going into care homes? Is all care home work via MS Teams? Do we just teach them lots of IT skills and get them good at MS Teams? You could argue they can help with a care home ward round on Teams because they can be logged in a separate room and be socially distanced. But actually, if you've never been into a nursing home before, actually, what kind of experience is that if you don't really understand what any of this involves? Things about MDTs and virtual wards, which are almost the least weird of anything, because a lot of that does translate directly across into doing it electronically. What about all our lovely informal opportunities when we chat to people, when we get to know the team, when you make somebody else a cup of tea? If you have a no making cups of tea for other people policy, that little bit of human kindness is gone. What do you do about sitting together having lunch? Presumably you don't. Do you? Do you take them out for a walk? Do you decide that you're going to have all your lunches on sunny days, put your coat on, let's go and have a picnic, because at least you can actually see their mouth for the first time in 6 or, you know, in a week, because you can go outside and not have a mask on. But what are your patients going to say if you're sat in the park having a picnic without masks on and the patients walk past and they think that you're flouting social distancing rules? You know, there's all sorts of ethical stuff about that. And what do you do about your tutorials? Do you go in the room together? Do you use Zoom? Do you use Teams? So that was what was on my worry pile, or my things to think about pile. Has anybody else got any other things that they were doing? I can't see nobody's added anything to the chat. So was there anything else that was on anybody's lists that I have failed to consider? So if there are, stick them in the chat now. Just looking at people's faces to see who's concentrating really hard and typing. Is anybody just typing really slowly? Yeah, so yeah, good point about thinking of induction based on trainee skills. So it's going to be really different, isn't it? Because actually, if you've got an ST3 coming back who was with you in ST1, and yeah, really good point out. Yeah, thinking about burnout. Yeah, lots of risks of us being burnt out. Also, I suppose one of the other things is thinking about what they've been doing, and do they actually need a load of nurturing and hand-holding? Because actually, if they've spent 8 months working in, I don't know, Red A&E, or they've come from elsewhere, because actually we know that Chesterfield hasn't been desperately hard hit. But actually, if we've got somebody that's relocating from having just done F2 or a trust grade job somewhere in the West Midlands or in North London, they may actually be very broken. very burnt out, very isolated because they're now moving areas as well, very unsure about what's going on, and have seen stuff that most of the rest of us, fortunately, probably haven't seen. And yeah, that risk of, okay, there's fewer of us around over the summer, so it's always pretty rubbish that they rotate in just as everybody else goes on holiday. And also, yeah, what exposure, what's going on? Are they going to be bored? What are they going to learn? Who are they going to see? And I know some of you were saying actually not seeing kids. I mean, hopefully in September, if all children are going back to school, we'll all of a sudden start seeing kids again, though then of course they may all be febrile and be going off to Red Hub if you're working in a practice that has a Red Hub service. But at the moment, of course, you realise that actually the vast majority of childhood illness is infectious disease, which is picked up at nursery or a soft play centre or at school. And since kids are not going to nursery, soft play centres or schools at the moment, we're not seeing it. We've not seen any chickenpox. Well, I've not seen any chickenpox for absolutely ages. One of my trainees was saying they've never seen chickenpox because they've only done general practice during COVID. And yeah, that risk of them having mental health problems and needing lots of pastoral support and all of that stuff, all those changes. What does GP look like? Is this the job they signed up for? Being kind to ourselves, is this the job we signed up to? Probably not either. What's it looking like? And actually those common GP problems that they may have to be learning about in the abstract when we start talking about common infectious diseases, tonsillitis. I mean, I guess teaching patients how to take good photos of the backs of their throat, great. But actually physically examining a throat, they're not going to be able to do that. So there's all sorts of things that are going to be different, and everything's changing in the exams. And not knowing patients as people, and it's hard enough, isn't it, that actually when they're new to the patients, they don't have any of that history that any of the rest of us have got. It's hard work, and it's really hard work talking to people on the phone when you've never ever seen them before. You've never met them, you haven't got that relationship. That's really, really difficult. And actually that trust your slightly suspicious patient, this is a new doctor, I don't even know what they look like, I don't know who they are. And maybe some of that can be mitigated by encouraging them to do a lot more video consulting as opposed to phone. Just sort of thinking about all of those as ways round. Brilliant, love it. Somebody's come for some positive. Yeah, building resilience, absolutely. If we can get through this, we can do anything. I think that is really important, and actually seizing opportunity. And I suppose perhaps they're going to be less stuck but we've always done it like this, because they haven't got a clue what anybody's ever done. But I agree, managing risk remotely is really, really tricky. And before, we've always said to them, when they've started doing on-call or triage, if in doubt, just bring them down. Well, you can't do that, can you? You can't say if in doubt, bring them down, or if in doubt, bring them down to the one doctor who's seeing patients face to face, who is already overbooked. How does that work? The team, with the team and things like that. So I think we've got lots of ideas here, so I'm going to kind of move on to the next bit, really. So I suppose one of the things I was just thinking about is experiences that you have had. So I'm just going to put up my second poll, which is just about experiences with shielded or extremely distanced registrars. So yeah, have you had an experience before or not? Okay, hoping everybody has voted that wants to vote. Not everybody has voted, though. I'll just give you another few seconds. Okay, so I'm just going to finish that and share the results. for a minute. So if we're just thinking about them, so one of the things that's worth being aware of is we don't actually know. So it's something we raised with HEE today, that we actually don't know if this is going to apply to any of the August starting ST1s, because that's going to be an enormous difficulty, isn't it? Because actually somebody that had already done 4 months of GP that was staying on with us, or maybe even more than 4 months of GP, who then ends up working at home, we've got a sense of who they are. They've bonded as part of the team. We trust them. We know how much supervision they have been needing so far. You can make a decision about whether you think that they are safe to be doing some work remotely. That's going to be an enormous ask of a brand new ST1, and I think that is going to have a whole host of difficulties, and we just don't know if there are any of those. There are a number of ST2s and ST3s in that category. Several of you have got ST3s who are in that category and are going to stay in that category, and you're working along well with them and it's all going fine. There will be some ST2s, and one of the things that's interesting is, of course, obvious things that can suddenly, somebody might well be risk assessed at the beginning and not be stringently distanced, and then they have a positive pregnancy test that they weren't expecting, and all of a sudden they're going to have to tell somebody and go home. So actually that again is or be in a room and stop seeing patients face to face. So there's that kind of emotional impact for them of sharing news that they didn't necessarily particularly want to share, as well as the supervisory issues. So the lead employer is meant to do occupational health assessments. They're meant to do a risk assessment, and if anybody identifies anything that could put them at risk, they're meant to use the risk assessment tool, and if there's any doubt, send them to occupational health. There, of course, will be people who haven't requested a risk assessment, haven't got a clue about it, are just really disorganised and haven't sent their forms back. So they're really important. And of course, as a host organisation, we as practices have got a responsibility to do some kind of risk assessment. Now, we should be risk assessing every single registrar we host, as we are risk assessing every single member of staff. My pragmatic approach to this, which we talked about the other day, is to say, okay, do your own risk assessment. The lead employer has probably done a risk assessment, and go with whichever is the most cautious of those assessments, because sometimes they don't marry up. Sometimes the lead employer is saying, oh yeah, that's fine, they can just see green patients. And actually, if your in-house risk assessment says this person shouldn't be seeing face-to-face, and none of the permanent clinicians would be seeing face-to-face if they were in that risk category, the fact that they are employed by the lead employer, I don't think should trump that. I think you should say whatever seems to be the most cautious is probably the most effective way of keeping them safe. And we hope there's not going to be a huge amount of conflict, but if there is, then it's perhaps about going back to occupational health. So if the lead employer risk assessment says something, yours says something else, they are employed by St Helens, there is occupational health, actually bounce it back to occupational health for them to make a decision about what they could and shouldn't do. And I am very mindful of the ST1s that are starting. About 90% of them are from BAME backgrounds, so they've already got one big risk factor. So actually they only need to be also obese, diabetic, pregnant, asthmatic, and they may well be at home. And I realise that's a nightmare, and we don't know anything about any of them, and it's going to be really difficult for you. It's going to be really difficult for them. Really hard. Hello, welcome to your first day. What are you doing here? Please leave. Go home. We'll ring you later. We might send you a laptop. Doesn't feel very welcoming at all, does it? But it's just worth being aware of that. And also that the CCG should be providing IT. So hopefully most of you have got a stash of laptops. If there is a problem getting hold of additional laptops from Next, which I am reliably informed by a man from Next who I asked last week that they think all practices have had as many laptops as they wanted. I don't know if that is true. Some of you may be waiting on laptops, but if you're not, again, if somebody needs remote access, HEE do have some access to some funds to get additional laptops as well, though they probably should be coming via the CCG. But if there is some insurmountable reason that means that we can't get hold of them, then it is worth making the programme office aware, and we can escalate that to HE to see if we can get you some kit. So that's kind of shielded and stringently distanced, how you identify them. Obviously the issues of then what work they do. One of the things that's being talked about at a deanery level is saying if people are not seeing patients, if they are doing work, then that can count towards training. So for instance, I'm aware of a couple of trainees in late pregnancy who are doing significant amounts of audit, quality improvement, guideline revision, presenting things. So there are all sorts of other developmental things that they might be able to be doing. So actually you may be in a situation perhaps where you get somebody, I mean, I don't know, there may be somebody today who's meant to be being inducted into your practice in August, who's actually going to go on maternity leave in September, and you're thinking, well, actually, what on earth am I going to teach you? And actually, you're put after 28 weeks, the workplace is not COVID secure. Should you even be in the building? Actually, for them to be supported at home, joining you for coffee on Zoom or Teams every day, coming to some tutorials, but actually reviewing nice guidelines and doing a load of other developmental work might be the answer. There's all sorts of stuff out there, and again, if you end up with somebody in that group, they're going to be specific circumstances. You know, please do get in touch with one of the PDs, and we will try and help you through the minefield. So I kind of came up, we've divided these things up, things that don't really need much thinking about or changing. So getting them to do level 3 safeguarding, e-learning for health or blue stream. I think they ought to be doing it. Certainly in our practice, I've always made them do that before they get to see any patients on their own. That's a really useful half day of induction to get them to do. Don't make them do it in their private study because they might not do it. And actually, if you really want them to do it, get them to do it. So actually, if they've done their level 3 safeguarding children on e-learning for health or blue stream and written a learning log entry, that's half a day of induction done, gone. Really important. And then of course they need a tutorial about how does that actually really work in practice. But actually, if they've never ever seen children before or never worked in the NHS, a bit of a sense of what is the theory behind child safeguarding before you start having a conversation with who is the safeguarding lead, what is a safeguarding meeting, how would I raise concerns, all of that stuff is important. Adult safeguarding may well be worth getting them to do that as well. Any other organisational mandatory stuff, information governance, fire safety, whatever else you as a practice want them to do. And let them do it. And again, actually have that discussion. Actually, if they're going to do that sat in a room, or actually you're going to let them do it at home. It doesn't really matter. That's things you can do. And clearly things like fire safety, touring of the building, they're going to have to wear a mask, but that's not going to be dramatically different. So some of that stuff doesn't really need an enormous amount of changing. Things that need a little bit more thought. So thinking about the first meeting, and particularly I was thinking, we're all thinking about induction of people who are coming to the practice, but lots of you will be getting trainees, your new ST1 who doesn't actually come to the practice until December or April. And how do you meet them? Because normally you go, oh, brilliant, come over and join me for coffee. But actually you might want to do that differently. So that might be different. How do you have your sort of first sit down together to talk about things? And thinking about tutorials, how are you doing them currently? You're going to carry on doing it like that? You're going to do it differently? Are you doing them? Are you using Teams or Zoom or Google Hangouts or whatever else you're using for tutorials? Or are you doing physical tutorials? Are they going to stay the same? Are they going to change? CBDs, I mean, you're clearly not going to do those in induction, but again, actually doing a CBDs work absolutely brilliantly. Doing it on Zoom or doing it on WhatsApp video or any of those other things, actually that hardly requires any change at all from doing them face to face. So that is one thing that isn't very different. But actually observing, how are you going to do that? Wearing masks, risk assessing the rooms, full on PPE, how are you going to do that? Does need some thinking. And stuff about emergencies in practice, how do you do that? What happens about, pressing emergency buzzers, resus, making sure that they are aware of the differences in what we're doing BLS wise now versus before. Are they going to be fit tested for an FFP3 mask so that they can do hands-on BLS, or do you have all your other people and you're going to say to them, look, you mustn't do this, stick the AED on, run over, but you're not allowed to do chest compressions? That might feel very, very strange to them, depending on where they've been working before. Face-to-face clinics, are they going to do some face-to-face? Are they going to do a bit more face-to-face? Are we going to let them do quite a lot of face-to-face because that's easier? Maybe, don't know. How's that going to look? What about observing things like COTS, audio COTS, observe videos? I had a bit of a play. I don't know if anybody knows, anybody that's more techie than I am. I have a feeling because I managed inadvertently to join an AccuRx call twice. So I was there twice and the patient was there once. I have a feeling that it may be possible to have 2 doctors and 1 patient in an AccuRx call. And if it is, that may well actually be a really helpful way of observing. Otherwise, it may well be thinking about innovative approaches like being logged in on Microsoft Teams and then sharing the AccuRx screen to be watching them video consult if we can't be in the room. So it's actually, thinking about some of that tech stuff. how do they get to work? Because we assume, don't we, and we say to them, you need to drive, but we all know that some don't. But actually, if they come on the bus and the buses are all really stringently distanced and it's a busy bus and it's September and all the kids have gone back to school, actually how accepting are we going to be on start times and things like that if actually it takes them 3 buses going past before they can get on one that's actually got a seat? That's not anything we've ever considered before, really, is it? Because other than there are a few buses on school bus routes that tend to get a bit busy, but generally speaking, round Chesterfield, getting onto a public transport bus is rarely very crowded, but they may well be really crowded now that the seating capacity has been reduced significantly. And what about the risk? And there was an SEA in Nottingham with a trainee who lived in London who was commuting and was getting a National Express coach to London every weekend, and her practice really weren't happy about the risk that she might be bringing into the practice from having sat on a National Express coach for 3.5 hours there and back every weekend to see her family. They were saying, well, actually this is conferring too much risk to our practice, and how do we deal with that? So again, that's something else that you might want to think about. And then things are going to be really different. So visiting, observing them face to face, how you assess if they're any good for CEPs, phone calls, PPE drills, emergency care, learning about the stratification, red and green, what is a hub, going to hubs, how does that work, being off sick, because we've all learned this, haven't we, that actually you start coughing, you go home, you get a COVID swab, somebody gives you a laptop, you feel really annoyed, you stay at home, you hope you don't get too sick, you might work at home, you might be off, but actually for every cough they're going to have to go home, and it's going to be winter, and that's going to happen more and more, and so actually our entire workforce is going to be decimated. But actually it's very different, isn't it? And our very presenteeism culture within medicine is going inevitably to change, potentially for the better, but actually explaining to them actually nobody's going to mind, but actually you've got a temperature, you mustn't come to work, that's going to be very, very different and potentially tricky to enforce. Think about that, endlessly building rapport. That's why it's tiring when you're in a new practice, because you've never met anybody before, but they've never met anybody and they don't know what they're doing, so they're going to be really tired, and they're going to be struggling to build rapport. Think about their pastoral care needs, especially if they've been really brutalized by their last 4 to 6 months. We may actually just be building them back up and trying to provide a lot of nurturing and pastoral care, because we don't know what they've been through. And like I said before, stuff about coffee and lunch and all of that is just going to be vastly different for them. So what I'm going to do is send you off again to have a think about some of these things. And what I would suggest that you do is has everybody know about whiteboard in Zoom? If you don't, once you're in your breakout room, if you click share screen, there's something that comes up as whiteboard which you can type on, and that's probably going to be the easiest thing. So if you share that, and then whoever is going to be your spokesperson can save that and then represent it when we come back as a big group. Does that make sense? So yeah, just thinking about troubleshooting, solving some of those problems together. So I'm going to send you all off again into groups, just checking nobody else has joined us that wasn't here before, that isn't in a group. Brilliant. So I am going to send you off for a little bit of time, and then we will all come back. So hopefully we are all back from breakout, and I've got some ideas. So if we start thinking about presenting any top tips from rooms and what you've done. So I'm trying to think in no particular order. You of course won't know which room number you were in, but I will start off with room 1, which was James, Wally, Veronica, and it says Simon, but I think there's more than one of you in the room, so it may be the Matlock people. Just whoever was the spokesperson from that room, do you guys want to go first with your top tips or thoughts or things that you've thought about from today that you're going to do?
Yeah, so I was nominated as spokesperson. Sorry, I've got my puppy just coming here. Just going to, I'm in a comfortable position before we proceed. Sorry about that. So we talked about trying to get as much information about the registrar before they start as possible. So getting to know them. setting up potentially a virtual meeting beforehand to find out about practicalities, whether they drive, whether we can get the risk assessment information so that we can set up an appropriate induction for them. So again, establishing email address. We talked about NHS email and access to Microsoft Teams. Talked about maintaining morale really through all of this as well, and pastoral support with regular meetings if they're remote to the practice initially, or if they're working in hospital posts and we're educationally supervising them. We talked about making sure that communication is good, evolving changes, and to just be awareness of different staff views, so anxiety levels amongst different members of staff and how the pandemic's affected people and attitudes within the practice. We talked about backup plans for supervision, so for staff absences that needs to be considered, and supervision for registrars when people are absent, whether that's admin staff in key roles or educational clinical supervisors. And providing registrars with information about the practice before starting as well. So I think a lot of it was about sort of being proactive and forward planning before the registrar starts in post or in that initial induction period.
Brilliant, that was really helpful. Thank you, room 1. So next group I'm going to go down to is the group that was Caroline, Dave, Naren and Naveen.
That's me. Let me just. Can everyone see that? Sorry.
Yep.
Cool. Obviously, agree with everything that Veronica said. Getting to know the registrar, things like the kiddie ring interview, etc., virtually perhaps. Naveen, well, particularly like the idea of asking the SD1s to complete the level 3 child safeguarding and some Blue Stream training as well. Logistically, obviously you're going to be working through telephone triage with them, different way of face-to-face consulting with donning and doffing, etc. But examples would be booking patients into red hubs or referring to the visiting teams. Caroline made a good point about creating a checklist, particularly about doctors' bags, not forgetting the stuff that we're already doing, maybe. And asking the ST3s who are outgoing perhaps to create an induction checklist as part of a QUIP project. Shared some concerns, particularly going back to what Tara said about trainees who've got that cough, that fever, especially with autumn and winter, and they might be asked to remote work. Are they competent? Do we feel safe to let them do that? Naveen made a very good suggestion of using AccuRx on a home visit. So by the way you do that is by typing in the registrar's mobile number, and obviously getting consent from the patient, perhaps doing a video consult that way, so, and negates the need for the trainer and registrar to go out perhaps. So just a few things really.
Yeah, brilliant. So I really like that, and particularly that idea about the visit and using AccuRx actually to be observing the registrar with, rather than to be doing a video consultation. Yeah, it's a really innovative use of tech. So brilliant. So next group was Jenny and Tom.
Let's see if I can share mine. And that seems to be a blank one, so I don't know how. I'll just talk you through what we talked about, and much of the same sort of stuff. The other things we mentioned were with regards to. So we had a couple of ideas in terms of. So at the moment, at our practice, we're having lunch in the car park, not on days like today, but when the weather's been good. So we sort of told everyone in our practice to bring a camp chair in the back of their car, so that we can all have our own camp chair sitting outside. So if there's the opportunity and the weather's good enough, then you can sit outside without wearing a mask, and that's quite a good way to do things. Tara mentioned that at her practice they're doing Tai Chi in the car park. I don't know whether everyone wants to do that, but sitting outside and doing it that way. Or alternatively, if you can't sit 2 meters apart in the practice, you could sit a meter apart in the pub. So that's another option.
Excellent. Thank you very much. Okie doke. Next group was Helen, Rebecca and Rosemary.
Don't think any of us volunteered to be spokesperson, but I can say a few bits. And we didn't find the whiteboard, sorry. And ignore the snoring noises too. So Helen had quite a few ideas that they've been using in their practice. Space for the registrars is a bit of an issue. And one idea I thought was really good, where you've got a room that's large enough, having people with headsets and splitters so that you can do your remote consulting in a room with other people, but confidentially. So I thought that sounded quite good. Balancing your lack of rooms by timing tutorials when too many people are in, and sending ST3s off for educational activities like attending PCN sessions. So it sounds like quite a lot of lateral thinking ideas going on. And the other one, another one that was quite interesting was for people who are working remotely and not patient contact at all, watching YouTube videos about how to do certain examinations, such as a breast examination, and doing a learning log entry about it. Apparently that might be acceptable, or has been said to be acceptable by the college. And another idea I liked was really being organised with the cars for home visits for the registrars, because it is a bit of a nightmare, isn't it, donning and doffing your PPE. They need training on that. Simple one, cardboard box lined with a yellow bag to help you donning and doffing, because otherwise you're getting in a tangle with your bags and things blowing away. What else? You talked about AccuRx as well. Yeah. Anything else I haven't mentioned, Helen and Rebecca? Need to unmute yourself.
Brilliant.
Yeah, I think covered everything, Rosemary.
Yeah, the rest of the stuff we talked about has already been covered by others to do with early risk assessments and being proactive on seeing what your registrar is able to do and confident to do, and benchmarking their anxiety and putting in that additional mentorship.
Brilliant. Thank you very much. So next room, which was Paul, Fran and Chelsea.
Okay, I think I'm here. So again, probably a lot of things that you said before. I mean, obviously there was bits we talked about. I think you listened in, Tara, about trying to have very early contact, pre-attachment contact with the trainees to try and stuff. Possibly will be running away on their holidays for the first couple of weeks as soon as they arrive, which won't be good. So that's good to make sure they're feeling that they're going to be part of a welcome team, however strange and different it will be. Just a few other sort of things in terms of the induction generally, making sure, luckily we've got F2s in at the moment, we've got STs at the moment, actually asking them honestly about what they felt was useful with previous inductions. Because often, we have that sort of formulaic, this is what we do because we've done it before. And they're usually very nice, the F2s who've only been there for 4 months, say, oh yes, it was great, the induction was brilliant sort of thing, but getting a real honest opinion from them. But also then in the contacting the new trainees before they come, being very open and saying, this is actually what we're thinking of in this new environment. What do you think is going to be useful for you guys? Doing it in a very open and accepting way so that we can try and mold it. We know what things they definitely need, but there's obviously lots of things that might be less useful. Induction could be shared with other practices as well. Certainly, say if you wanted the hub of midwives to be a little bit, give a half an hour talk, that could be shared with trainees in different practices, say the Claycross trainees, along with our trainees and various other ones could dial in at the same time and work together virtually with that. certainly listening to Chelsea from Birmingham, she was saying about how they're sharing their training going forward as well with other practices. So taking the specialisms like we've obviously done, if there's a particular person who's good with or using group training rather than just practice trainees. Even if you've got 4 or 5 of them, you might have a resource that you can share amongst 15 or 20 trainees, as long as we don't obviously overlap with the VTS with those things. Other things, obviously, really important to make sure that we make sure our practice communicates with our patients about the trainees being in, and also how assessments might happen. If we're lucky enough to have big enough clinical rooms to potentially have more than one clinician in at a time on the odd occasion a face-to-face patient comes in, making sure that communication goes out to patients, both at the time of contact with the phone, but also maybe social media, practice websites, that sort of thing.
Brilliant. Thank you very much, team. You look like you've covered loads there, and now we seem to have lost Paul, who's sort of frozen in the ether, as Zoom tends to do to people. So then next room was Maggie, Liz, Tracy and Vic.
Right, there we go. I think we haven't really got very much more to add, because all the practical sort of solutions people have come up with have very much mirrored what we were thinking as well. And we thought, yeah, there wasn't really, we thought the use of Zoom and Accurix are key to kind of to teach them fairly early on how we're utilising IT very differently now. And the induction at the start, I think we felt probably needs to be on a one-to-one level, trainer and trainee, a little bit more intensive than we've ever done before, just because we need to probably know their capabilities quite a lot earlier and in a quicker fashion before we can really sort of allow them to do independent working, which they might be doing at an earlier interval than they ever used to, particularly ST1s. But otherwise, I think a lot of our practical solutions have already been discussed.
Thank you very much for covering ground. I think we were doing qualitative interviewing. This would be called saturating, wouldn't it? I think there's no more new themes coming out. Has every group spoken, or have I missed a group? I've now feel like I've lost the ability to count to 7. Every group's had a go. Nobody's feeling left out that we forgot you. Brilliant. So, anybody got any other comments? So we had a comment on the chat from Naren, which I agree. If you haven't all discovered eGP Learning, eGP Learning is a really, really good educational resource run by a GP from Nottingham, Dr. Gandalf and Dr. Hussein Gandhi, who is amazing at tech. But who has done loads of stuff about virtual examinations and teaching virtual examinations. He's done an amazing video for patients on how to take a decent throat photo of the back of your throat. So anybody with a sore throat, we now send an AccuRx link to that and say, please watch this YouTube tutorial and then text us back a picture of your throat and then I'll ring you. There's all sorts of stuff on there. He's done shoulders, knees, neuro exam, bits of ENT, all sorts of stuff on there. And he's also a GP trainer, and there's loads of interviews with other interesting people. There's loads of stuff if you like that. And Selena has just reminded me that he is also running a tech trainers meeting for us at some point over the next few months as well. But if you're thinking about where should you direct people for examination, there's those. And there's also some videos which we sent out a link from the VTS office a few weeks ago from Wessex. Wessex have produced a load of how to examine patients videos as well. I have to admit, in a tutorial, Naren and I did look at quite a lot of them with our registrars, and we decided that we liked Gandhi's videos better. Sorry, Wessex people, but you might like one or other set that's probably worth having a look at those as well.
He's also doing a System 1 conference on the 24th of July. Sounds 25 quid. Sounds quite good.
Yeah. So yeah, there's quite a lot of good stuff going on via eGP Learning. So that's somewhere that's definitely worth knowing about and signposting them all too. And of course, if you've got ST3s, it's just worth thinking as they start heading towards doing this RCA that's replaced the CSA for now, they will start getting access to the 14 fish RCA video software stuff, which actually is brilliant for even if it's not ones that they would be going to submit for the exam. It's so easy and so brilliant to review and do COTS and give them feedback on. That's really, really nice as well. So when your registrar gets that, really make the most of using it, because it is really so nice for reviewing cases on, compared with any of the other stuff that we've got. So mindful we've been a while, so I'm hoping kind of getting towards the end. Any other comments? So yes, Naren's pointed out, hopefully you've all seen the emails. If not, there is an RCA webinar next week for anybody that's not done an RCA webinar already. There's another one, though I wouldn't worry too much if you're really busy next Wednesday. Angela Sharman is doing our August trainers workshop, which will all be about the RCA. She has spent the day locked in a small room with noise cancelling headphones and a couple of laptop screens marking RCAs. So when she comes to the trainers workshop in August, she will not only have all the theory as being an examiner, but will also have some really good practical experience of actually really truly what they're looking for, and what it was like and how they mark the cases and things. So probably worth timetabling that August trainers workshop, which I suspect Angela will be happy to record for people who are on holiday. So if anybody's got anything else that they want to say, please feel free to wave your hand in the air, unmute and shout up now. Otherwise, we might call it a night. Thank you very much all for coming. We will collate some of those thoughts and ideas together and then sort of send out a big list. If anybody did save their screen share that was using Whiteboard, if you did save it and you want to email it to me, that would be brilliant, because that would save me transcribing my notes. If you've already got them written down, it'd be really, really helpful if you could ping that across to me by email if you did save it. Otherwise, thank you very much for coming, and thank you for everything you do. Thank you for being brilliant trainers. It would be a nightmare as PDs if we didn't have you. And before I go, I'm just now going to embarrass somebody who started looking at the floor, Veronica, because this is Veronica's last trainers workshop as a PD. So it probably hasn't escaped your notice that we are losing the wonderful Veronica as a PD at the end of July. Fortunately, not losing her as a trainer. But yeah, it's an opportunity, I think, for us all, I hope, to say a big thank you to Veronica for everything she's done, and probably make her blush by all giving her a big thumbs up or a big clap before we go to say thank you.
Thank you. I'm not going anywhere. I'll probably still be here in August, but just in a different capacity.
Excellent. Right, thank you very much, folks. Thank you all for coming. Cheers, and see you all soon.
See you.
Bye.
Bye.